Hey everybody, today we're talking a little bit more about how to know it's not Hallux rigidus. And basically what we're looking at here is that it is, a lot of these conditions that we're going to be going through, they're really about that first metatarsophalangeal joint or that first big toe joint, and really making sure that we've got the right diagnosis. With Hallux rigidus, it is late stage osteoarthritis. With Hallux valgus, it's, and this could be Hallux valgus in a late stage, but really with a bunion or Hallux valgus, that intermetatarsal angle between the first and the second metatarsals, they're going to be increased, or the Hallux valgus angle, that deformation of the hallux moving across towards the second toe, that's what you're going to be seeing in contrast, potentially with that joint degeneration that we see in Hallux rigidus when it is at that later stage. Now, Hallux limitus and Hallux rigidus are the same type of condition, but at different stages of their concern. With Hallux rigidus, we're starting to see a lot of osteophytes, lack of joint space. There could potentially be cysts on the x-ray, whereas Hallux limitus, there's going to be a preserved joint, although that joint might be squared off a little bit more. Typically we're going to find the difference in particular with, when we're not standing, that joint's still going to have really good range of motion. We'll also see that on Hallux limitus in our neutral calcaneal stance position, we can get that really nice range of motion, whereas Hallux rigidus, we still won't be able to get that range of motion because the joint is degenerated, such as in this x-ray image. Now, things that can lead to Hallux rigidus are gout, and so we always need to keep that at the back of our mind with regards to differential diagnoses or other conditions that it could be. And gout is one of those inflammatory arthritis, and if it's red, hot, swollen on top of what you would expect from an arthritic joint, then definitely having to think about gout and undertaking some of those tests around that could be a really good option. Similar with our Joplin's neuroma, it may be that there is a bit of a nerve entrapment causing some nerve inflammation. And typically if we're getting a positive sign from a Tinel's, where we're percussing very softly around that dorsomedial aspect of the big toe joint, or to the side of the big toe joint, then that's when we're more likely to have a Joplin's. And people will usually say that there'll be sharp shooting, tingling, potentially some numbness that goes through into their medial hallux. And that's what I'd sort of suggest might be a Joplin's neuroma there. And it could be with our Hallux rigidus or joint degeneration that's occurring at the same time. It can be quite common. Other things that you just want to be aware of more globally around this joint is that there could be some plantar plate pathology, and we can find that out by doing a bit of a dorsal draw if the joints are mobile. And patients are typically going to find this uncomfortable. And so just assessing whether that pain's more at the top of the joint or at the bottom of the joint, doing some direct pressure onto the plantar plate. And then similarly for the sesamoiditis, we want to make sure those sesamoids are comfortable. And if they're not, whether they might be arthritic or potentially, fractured. So we just need to make sure that we're really palpating across that medial and lateral sesamoid to rule out any potential, sesamoiditis that may be there as well as the Hallux rigidus, or maybe just something that you've missed prior to thinking about the Hallux rigidus as well. But hopefully this has given you a lot of great information about, our differential diagnoses for Hallux rigidus. In the meantime, subscribe, check out some of our other videos, and we'll see you on the next session. Cheers.